Hello, everyone, and welcome to today's webinar titled Recent Developments in the SARS-CoV-2 Landscape and Testing Strategies to Address this Constantly Evolving Field. This webinar is part of the Clinical Diagnostics and Research event, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and sponsored by Thermo Fisher Scientific. For more information about our sponsor, please go to thermofisher.com. Now let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to participate. First, by communicating with other attendees using our new live chat feature during this presentation. You can find that live chat feature located on the right of your screen. You can also participate by submitting as many questions as you want during this presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of this presentation. If you have any trouble seeing or hearing this presentation, just click on that Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits tab located at the abstract window below the presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Manoj Gandhi, a Senior Medical Director in the Genetic Testing Solutions at Thermo Fisher Scientific. For a complete biography of our speaker, please visit the Biography tab at the left of your screen. Dr. Gandhi, welcome. You may now begin your presentation.
So thank you all for being here. Before I start, I always like to talk about these three things. One is, we always talk about different tests. So what is a diagnostic test? What is a surveillance test? And what's a screening test? There's always these three terminologies we use a lot. So diagnostic test is something that we use, that is when someone presents with a symptom, is falling sick, presents to the hospital, or maybe even is suspected of being exposed to the virus. So maybe in some case of a contact tracing, you would test these people, and that's a diagnostic test. A screening test is when you are testing when someone is not suspected of symptoms. You're just going and getting yourself tested, like we took our test when we came here. Or you're going to and getting yourself tested before you're boarding on a plane. So that's what is called screening. And then the third part is surveillance. And surveillance is a little bit of an interesting topic because people use surveillance in monitoring, whether it is serology, what is the prevalence, incidence. For COVID, it has been a little bit interesting because we want to not only know the prevalence and incidence, but we also want to know what is the variant and what are the different strains of the virus that are circulating in the community at a specific given time. So what we have, and I'm going to be talking about, today I'll be focusing a little bit on surveillance, which is about this different strains, and you heard probably in the plenary session talking about where we are and where, what might happen with the Delta and where sort of the vaccines might play a role. And these are some of the sort of concepts, right? We've heard these names, we read it all the time. So what's a mutation? What's a variant? And what's a lineage? So the mutation is specifically a change in the nucleic acid, in the sequence of the viral genome. That can be either a single nucleotide deletion, a change, there can be a modification, or it could even be a sort of a deletion of a larger set of nucleotides. And you'll see that happen in one of the variants that actually happened with the UK variant, or the 117, or the alpha variant. The variant is when you start having a set of mutations that together constitutes what is called as a variant. And then what is a lineage? A lineage is a specific branch of the descendant of the tree of the virus, and any specific branch of that would then be called a variant. So when we talk about these things, keep this in mind as to what I will be referring as to what is a mutation and what is a variant or a lineage. When it comes to how the CDC or the public health organizations have talked about this one, is they've given these names, whether it's a variant of interest, or it's a variant of concern, or it's a variant of high consequence. Fortunately, we don't have any variants that are of variant of high consequence. And I'll tell you why so far we don't have any ones that have been escalated to that level. A variant of interest is one that we know has sort of changed from the original sort of sequence of the virus. And we want to keep an eye on it. That is the sort of the concept of variant of interest. It's also we can also use it interchangeably by the word variant under investigation. A variant of concern, on the other hand, is something that has shown a little bit more. It's a little bit more higher sort of risk to whether it is going to cause severe disease or it's going to cause increased transmissibility. It might have some potential for vaccine evasion, and those are things that we need to really be careful about. It might even affect the efficacy of a diagnostic test, and you'll see some of it actually happening in positive and negative way. And then we have the highest category, if you look at the severity, is the variant of high consequence. And that would mean that we really have in a situation where the vaccines are actually not doing a job, or it's really causing high severe disease where people are falling sick. And that is something, as of now, as of this presentation, there is no variant in that variant of high consequence category. And now this is a slide that right part of it, actually, I worked on it yesterday night. So what was there was actually, this is from May of 2021, right? You can see, the sort of the phylogenetic tree of the virus. And you can see, obviously, at the time you had a lot of it was alpha variant, which is right. You can see in the orange down there. And you had a little bit of the beta variant. I like to go in alpha, beta, gamma, delta. So the beta variant, you can see that was the one from South Africa. And then you have the P1 gamma variant from Brazil. And you can see the proportion. And then you had a little bit cropping up in India at the time, which was the B.1.617, which was a delta variant. And this is September of 2021. This was from yesterday. This is from the outbreak info slide. And you can see what has happened instead is completely changed. You can see here now what was the alpha is now quite, in the large scale of thing, is pretty much taken over by delta. So now you're pretty much, in a matter of months, you have seen the landscape completely shift. You still have the beta, which is right here, which is this dark blue one. The gamma is still hanging around. And now, very interesting, you can see this little thing. That is actually the mu variant. Okay. So these are things that we need to keep an eye out. But you can see a completely shift and the domination of B.1.617 really taking over, and because of the high transmissibility of this strain. So I'll go a little bit into the details about these strains and tell you what are the mutations and then how these impact to the surveillance testing that is important for the next part of the presentation. So this was the first variant that was actually identified in September in the UK. And in December, around the Christmas time, we were actually seeing some reports come in from the UK talking about a very interesting finding, actually. And this was actually identified because of sort of a feature, an observation by the investigators in the UK. They reached out to us saying that, hey, listen, we are using your tag path assay, and we are seeing an interesting finding where you have 3 genes that are in your assay, and one of these targets are not amplifying. Is there something wrong with the assay? And we said, let's look at it. We looked at it. The assay was fine. Next thing you know, they did the sequencing, and when they actually sequenced, they found out that actually there was a deletion in a region which is what we were targeting, and that had led to that one target to have decreased sensitivity. But the other 2 targets were fine. So you were calling them positives, but they had a little bit of an interesting sort of a pattern. And that's how they actually identified the UK variant. And I'll talk a little bit about what we call the S gene dropout in my next slide. But they also identified a little bit, when they did the sequencing, they identified a little bit of the different mutations that you can see here. One of the ones that actually had the highest impact or the relevance was the N501Y mutation. And this you can see here. This is the N501. And this is actually the receptor binding domain of the virus. And you can see the N501Y here. And it is so close to the human ACE2 receptor because that's the one that actually helps bind the spike protein to the receptor and allows the viral the entry into the cells. And I just talked about the deletion. This is the deletion, which is a 6970. It's a 6 nucleic acid deletion. And it actually led to this, what we call now it is referred to the terminology we use is S gene target failure. And some people use the word S gene dropout. And this was the reason why they even discovered in the first place. And that's when we knew that this virus is really kind of shifting to a point where we are seeing these variants. And that became the first variant of concern. This was the first variant of concern coming out of England. And that was the one that basically quickly, rapidly spread across the world, became one of the most dominant variant. And this is, we're talking about, I would say, December, January, February time. At the same time, different parts of the world, the virus was evolving. Now the surveillance part of it, people were saying, okay, let's look and see what is happening in the rest of the world. This is about the dropout. Okay, so the dropout, before I go to the next variant, is the dropout. And this is we have a 3-target design in the assay, where you have the first target on the ORF1 gene, you have the S gene, which is the spike gene, and the N gene. And you can see this was the one that was constantly being sort of, not present while they were running the assay. Interesting, this is actually data that is coming out much more recently from September and October, July and September. And you can see this is all the S gene dropout because this is, this is the detectable S gene. You can see that during November and December, it's sort of, you have the green bars go down and you have the S gene dropouts now coming in, which is the S gene target failure. And see what is happening a little bit as we move into April, May, June. You can see now the S gene coming back. So the S gene coming back in the assay was sort of an indicator that, okay, maybe something is changing in this virus where we are not seeing the alpha variant now, and that is something that is different. And that's where they sort of identified a little bit more. In the meantime, there were reports coming out of India that this was actually a different variant, which was the Delta variant. So this is essentially the early rise of Delta variant in the UK, which is where you can start seeing that the assay is back to a 3-gene assay. Okay. So in short, what I'm trying to say is that the S gene dropout in the TAGPath assay actually is sort of an indicator for the presence for potentially the B.1.1.7 variant, because it correlates with the deletion of the 6970 nucleic acids. Similarly, what was happening across the rest of the world, we were seeing reports coming out of South Africa where they saw another variant. And this was called the 1351 variant, and it's now called the beta variant. This one had a different set of mutations. So I talk about the mutations and the variants. So they had a different set of mutations. One of the mutations that was there was, in addition to the N501, so the N501Y allows it to bind to the receptor binding domain and then allows it entry. But it had some other key mutations, and those key mutations actually are the ones that we need to worry about. Is this E484K mutation, and there's a K417N mutation. These are some of the mutations because these mutations in studies have been shown to have poor response to antibody therapy. So when they took the convalescent plasma from patients who had recovered and did in vitro studies, they actually found poor neutralization of these antibodies, and which meant that these people would not be responding to monoclonal antibody therapies, or even for the matter when they get vaccinated, when you have a build up your IgG and IgM levels, it could mean that now you have a virus that could potentially evade the mechanism and actually have the potential to cause more disease. So this is something that I think a lot of the sort of the physicians or the public health experts are a little bit concerned with the growth of especially the South African variant. As more and more of the people will start getting vaccinated because of the mutations it contains in the lineage, in the genome. Similarly, you look at the Brazilian variant, which is the P1 variant, or now it's called the Gamma variant. This came out of Brazil. It's almost seen in now 80 countries. It has, again, similarly, you have this N501 and E484. Now, it has this different mutation called K417T. The previous one had K417N. This one has a K417T mutation at this location, at the 417 location. Again, what the concern with the P1 is that, again, has a high binding affinity because of the N501Y to the ACE2 receptor. But again, very interesting, it has poor response to antibody therapies. Similarly, based on in vitro studies, looks like some of these mutations can cause poor neutralization of these antibodies from convalescent plasma. And then the big one that happened in India, which was this was, I would say, this the March of this year, March, April, May, where I showed you that the first three that you barely saw this started cases coming out of India, and then it just rapidly, completely it just exploded in the country. They have different. They have different lineages. It's actually called 1.617, but there are different sub-lineages of that. It's 1.617, 1, 2, and 3. But the one that is now called the Delta variant is actually the 1.617.2. That is actually called the Delta variant. It has a specific set of mutations. It has since then become the most dominant variant in the world. And I showed you that picture where it is kind of pretty much taken over, and it is rapidly rising, even in the US and rest of the world as well. In addition to some of these, what we call sort of parent mutations that are there are some interesting mutations. There's a word that was used when it first came out, was the word double mutant, because it had two specific mutations that was of concern. And these mutations are the ones in vitro studies showed poor response to antibody therapies. And one was the L452R and the E484, so Q. Now, I've been talking about E484K. This one is a E484Q. So there are slight changes, as you can see, between one lineage to the other in some of these mutations. And then you had another one, which was a triple mutant, which was, in this situation, had another additional mutation, which was P681R. When you add all these mutations together, as you can see, there is, the virus is starting to accumulate these mutations to a point where you start seeing these strains potentially get to a point where they might be either highly transmissible, or the worst possible situation would be that it starts becoming resistant to sort of vaccines. And this is where we started really, looking at it and saying, we really need to understand how this virus is evolving and find a way to do more of the surveillance testing, which is very key. Because this is, and we do surveillance testing for flu all the time. We know about flu A, we know about flu B, and that becomes part of our vaccines. Right now, our vaccines that we use for Pfizer and Moderna, whatever, J&J, they have a specific specific sequence that we all take. But we need to understand how this virus is evolving, because they might have an impact on the design of the vaccines. And you can see these are some of the mutations of concern that are there. And this is where you can see. And it's not like it is very unique to that. There are some of the what we call commonalities between the different strains. And it's very important to understand that this is the process of the convergent evolution of the virus. The reason why this is important, because we have to understand that the virus is here. It's going to be an endemic situation. The virus is here to stay. We have to know that the virus is going to evolve. It'll probably outlive all of us. And at the end of the day, we have to be able to understand every year what is happening with the virus and what is a different strain, because that strain will determine how we, what to expect. How do we, if at all, vaccines need to be modified. And these are some of the mutations that are there. And all of these mutations, when you look at, yes, where you put them together from a clinical standpoint, we need to understand when it all comes together, what it impacts to the patient. But each of these mutations, when they have done their studies, have shown, whether they don't respond to neutralization with antibodies and stuff like that. So very important to track these mutations as we go. The good thing so far, so obviously at this point I've been always talking about what are some of the concerns. As of now, and I've used the word as of now, because I don't know what will be there tomorrow. It could be completely different. The studies that show that the vaccines that we have so far seem to work. Whether it is the alpha, beta, gamma, or the delta, the vaccines seem to be effective. Now, I was listening to the plenary session, and there is some early data coming out that there might be some decreased efficacy, and that's where the real concern comes around is, do we really need to look at this data and really understand whether vaccines need to be modified at this point. Because the mRNA vaccine is an interesting technology, because you can just put another sequence in there and into these lipid nanoparticles and get another vaccine. Obviously, it has to go through the approval process, but it is easily sort of manipulated. But at this point, if you get 2 doses of the vaccines, it is almost it has the very good efficacy in preventing hospitalization and disease. And I use the word hospitalization and disease rather than infection, because vaccines do not prevent infection. They prevent disease and prevent you from getting sick. But the situation of going to falling sick and going to a hospital is much more complex than just getting infected, because it also depends on underlying health conditions, predisposing conditions, age. All of those make a difference in the efficacy of the vaccine. But so far, even with the Delta variant, the vaccines with two doses based on these studies and the last studies seem to be effective. But again, things can change because these mutations do go on. The latest variant that we were talking about, and this is something that I was putting this slides together, and there was a lot of discussion around mu variant. I said, I need to talk about mu. The mu variant it was seen in Colombia in 2021. It's seen almost now in 49 countries, and this, it keeps on changing. Today, it must have been by now. It must have been in 50, 60 countries by now already. There's a high mutation accumulation. It has, and all these mutations that I put on the slide are the ones of concern. You can see the N501Y, that seems to be sort of one of those backbone lineages on which new variants are being emerged. Obviously, at the first 614G, that was one of the first backbones. That backbone has stayed. It has now also been the N501Y. And you can see E484K is still there. K417N is still there. P681R, now you have P681H, that is in there. Now this new one shows up, R346K. And all of these mutations, in some ways, have shown in in vitro studies to having some issues with, or some sort of impact on the virus, on the neutralization of the antibodies. So not only does it have the increased transmissibility of alpha and delta, but also the vaccine resistance of beta and gamma. And that's where some of the concerns have been risen at the public health is what's happening with mu. Let's take a look at it and see what we need. Are we really looking at a strain that is emerging that is potentially maybe resistant to a vaccine? So right now I put these, it's still not been escalated to a point where it is considered as a sort of a variant of concern, but it is right now sitting at the variant of interest. So you have these 4 variants of concern, which is the alpha, beta, gamma, delta, but then you have mu sitting here, and it could very well quickly get into that, and the list keeps on kind of changing. The CDC will change their sort of variants based on what the prevalence is. Right now, obviously, the Delta is really taking over because of the transmissibility. Fortunately, the vaccines seem to work. So how do we do the surveillance? Now that we know that the strains are important, they will be changing, how do we continue this surveillance? I talked about what's a diagnostic test versus what a surveillance test is. So as we look forward, as again, what Chris said, what is next? We really need to know, and I think it is the right thing to do, is to do for public health labs to actually keep doing a little bit more of the surveillance. When you look at surveillance, I look at mainly as a triangle. When you look at any sort of a testing strategy in the lab, you have your standard PCR detection, which is used as your gold standard for diagnostic testing. When you now start looking at the right sort of this side of the triangle, you start getting into that hybrid situation of, getting into testing / surveillance. And we have a couple of technologies that I'm going to talk about. One is you have, we can confirm the mutation and just do the mutation verification by specific technologies. And then you can do what we have capillary electrophoresis, which is Sanger sequencing. And then you can have, which I'm going to talk a little bit more about today, is this mutation panel. And the reason I bring about the mutation panel, and I had spent all this time talking about the mutations, was because, as you can see, these mutations are specific to variants, and the set of mutations are pretty kind of give that variant its own signature. So you can use that signature and now start doing a little bit of an interesting way to do surveillance, which is using this mutation panel. And the third part of which has always been the classic sort of surveillance conventional method, which is using next generation sequencing. This is looking at the whole sequence of the viral genome. You're essentially looking at every single nucleotide. So you can detect the known variants, as well as if there's something that is emerging and novel, you can also see the new variants that are coming up. And you can still do the capillary. I put this capillary as common to both because it's a sequencing technology. So the mutation panel, this is an interesting sort of a concept. It's what we have right now is each of these mutations that I talked about, whether it was the 501Y, the D614G, 484K, E484Q, P681R, all of them are actually individual mutations that we have assays for that are sitting, and these are all mainly in the spike gene. And the spike gene is one of the areas of the viral genome that is going to constantly mutate, because that is the one that is under a lot of evolutionary pressure from the vaccine, because the mRNA vaccine is the vaccine against the S gene. It's an S gene mRNA against the spike protein. So that puts a lot of pressure on the virus to evolve. And you can see a lot of the mutations are happening in the spike protein. So we have all these mutations, and we keep on adding more mutations. The mu mutation is in there. And you have other specific genes as well. We have the ORF1A gene, the ORF1A gene, and you have specific mutations in there as well. And you can see this is an amplification plot showing specifically for the A484K. And you can see this, what you see here is the wild type. And the assay is a binary assay. Either you see the wild type or you see the mutant. And here you can see the mutation is a clear specific separation between the mutant and the wild type. So if you see the curves down, that's when you mean that that's the wild type. And then if it's here, it's a mutant. So you can easily tell which one it is. And this actually was from our collaborator from ABC Labs in Sweden. We actually have a poster if you want to stop by and see how Ola is using it in his lab for surveillance. The advantage of this sort of system is we have obviously this menu we keep adding this menu, but you can adapt this menu very quickly based on what is the prevalence of what strains are prevalent in your region. And if you look at, there's a website called outbreak.info, and you can go to that web page, and it tells you the prevalence of strain. It comes from the Scripps Institute for the last 60 days in your region. And you can basically look at the strains, and it also has a nice way of putting in sort of all the strains, all the kind of variants of concern, and any other strains that you want to add in there. And it tells you all the mutations. Based on that, you can quickly form a panel, and you can pick and choose from here, and make a panel for yourself. It uses the same PCR instrument and the same RNA that you have extracted for diagnostic, for the testing, for calling it positive, negative, and basically run this panel on the same instrument. And it gives you an answer within an hour. So it uses the same technology, same instrument, only now you're getting surveillance information within an hour rather than doing sequencing. And again, I'll tell you how you can kind of complement sequencing for surveillance. And this is what I was talking about. This is actually coming from that page, which I use, which is Outbreak Info. And I just listed here, I just looked at 4 variants. You have the alpha, beta, gamma, delta, and this actually shows all the mutations in there. And I said, okay, I just want to have a panel for my variants of concern, and I can easily pick and choose them. And based on that classifier, I can tell you now with this specific pattern which of the variants it is, rather than doing the entire sequencing. People have used a three MOC, I call them a MOC. MOC stands for mutation of concern. So you can have a 3 MOC classifier, you can have a 4 MOC classifier. You can see here, this person actually added a local variant in there. That's Ola adding its own, or I think it was one of our collaborators adding 1258 in there. This was adding P2 in there, which is another way, not P1. But then you can have just your 4 variants of concern. If you want to add mu in there, you can add mu in there. The other thing you can add is how much redundancy do you want built in your assay. So some people like at least 2 assays to identify a variant. Some people like 3 assays to identify a variant. So based on that, you can devise a panel and run it on the same instrument with the RNA that is already there that you extracted for PCR, regular diagnostic testing. What do we have for sequencing? From sequencing, we have two specific different methods. One is using the next generation sequencing. This is using, we have the S5, the Gene Studio Ion, and then you also have where you have the extraction and the sequencing, which is two separate instruments, and then you have the integrated Genexus sequencer that does both the extraction and the sequencing together. Now, this is, again, will give you the entire sequence of the virus. So you will know every single nucleic acid that is there, and it can go as low as 20 copies. Sanger is another way to do it. We have the Seq Studio and this 3500 and the 3700. And it's a cost-effective way of doing sequencing as well. We have published the protocols and the primers for Sanger sequencing specific for the S gene. And you can just order those, and you can run specific Sanger sequencing as well. And these are good for confirming the entire sequence, just to make sure. And the reason why I say to confirm is because you can certainly have, and again, I don't want to get into the whole sort of, you can look at, I can share this slide with you. What is the pros and cons. But the most important thing you can see is, here you can get these results in hours as opposed to, days. Again, you can get this in 1 or 2 days. If you have a good workflow in your lab. These are the instruments, as you can see. And you can see the targets here. We can, I've right now put 1 to 20, but those actually, it's grown exponentially since we added more on the menu. You can obviously have these different, looking at the entire genome here. This is the workflow that I was talking about. So if you get a positive sample, you obviously get the RT-PCR for detection for whether it is the SARS-CoV-2 positive or negative. Once it is positive, and you have already reported out to your health agencies, what you do is you essentially do the mutation verification based on these mutation panels very quickly. And most of them are going to be the ones that are prevalent. For in this case, if you look at it today, 99% of them are going to be the Delta variant. But there is still the mutation, the virus is going to evolve. You're going to see a new variant that is going to pop up at some point. So you can quickly run your mutation panel, and you can run them on many more samples rather than doing sequencing on a few. Because right now, when it comes to surveillance, the general guidance is, do about 5% of random sampling. With this strategy, you can actually increase the number of samples that you're doing surveillance for. And you can use that and upload it. You have your classifier, you identify your variant. And then if you do see that this is a variant that you're not able to classify, you can now triage that into a sequencing and now use sequencing only when you need it. Depending on how many variants you can, then you can decide when you really want to use sequencing. So this has been an interesting sort of approach by a lot of the public health labs that have to do these sort of strain identification to conserve, to first of all ramp up the number of sequencing ramp up the number of surveillance on number of cases, and use your sequencing when you need them. So that is a sort of approach. So I spent a lot of time talking about surveillance. The next thing that I wanted to talk about is it's an interesting time of the year. We are in, September, October, and this is when the flu season is expected. Last year was an interesting, I was having this discussion over dinner yesterday. Last year we did, we were asking the same question, are we going to see a flu season? What will happen? We use this word twindemic. There was a lot of media coverage around the word twindemic. They coined this term twindemic. It never happened. And then now we are back 1 year later having the same conversation. Where do we go? What do we expect to see? So again, it's just a little bit of a forward-looking thing, but again, I want to talk about it and see, what will happen. We will see in the next few months. But let's see the detection of why it is important to detect both influenza and COVID as we look in the next few months. So what is, before I go there, I just want to talk a little bit about influenza and about COVID, because it is very important to understand the similarities and the differences between these two viruses. So if you look at seasonal flu, it is caused by the influenza virus. In the northern hemisphere, we call it during the winter months, so it is between October and May, with a peak during December and February. And we will see between 3 and 11% of the population having symptomatic flu. And again, I say the word symptomatic because now we use the word asymptomatic and symptomatic. And it is the symptomatic that really is the key, because these are the ones that will fall sick and go to the hospital. But even you still have 75% of the people of the infections being asymptomatic, which means they can spread it to people who are, high risk, with underlying health conditions, immunocompromised, whatever they can be a little bit more predisposed to it. And has a very similar, it's very easily transmitted through aerosol that we know a lot about, respiratory droplets, aerosols, quickly communicated as well. Interesting, if we look at the statistics, we have about 45 million cases, up to 45 million. In a bad year, we'll get up to 45 million cases per year in the US. So it's not a minor number. And this happens every year. Last year was a sort of an anomaly, abnormality. Some people said, oh, flu is gone. It's not gone, it's dormant. But so up to 45 million cases can happen a year, with almost up to about 800,000, hospitalization, with 61,000 deaths. In a bad flu season, you can get that one. And the reason why I'm talking about the bad flu season is because the last year was a dormant year. We really don't know what has happened with the virus in the last 1 year. So interesting to see where we'll go in 2021-22. When you look at the two different, I put this side by side because you can see the structure of how these two viruses are similar and different. They look very similar, but actually they are quite different. They're in a different class. So both are RNA viruses, but one is an orthomyxoviridae and one is a coronavirus, which is a coronaviridae. And you can see the structure. You have, the sort of the capsule, and then you have these different proteins on it. And that is what you have. The two specific proteins are the hemagglutinin and the neuroaminidase. So that's why we use the word H and N. And you will see this word H1N1, H3N2. These are basically the two proteins that are on the outside. And with SARS-CoV-2, you have the spike protein on the outside. It doesn't have the similar H and N, but it has a spike protein. Again, a little bit more, you have the different strains, but again, you have one strain but different variants in SARS-CoV-2. So this was, when I look at the influenza, let's a little bit look at influenza A and influenza B. So influenza A has these two specific ones that are right now predominant one, which is H1N1 and H3N2. These are the two currently circulating strains. And you can see the sort of the graph every year. You would have, during the winter months, you see a spike and then it go back. And this is the seasonality pattern that we have. And again, you see 2020 here, a big miss. There is a gap. So, obviously it was all the public health countermeasures. Everybody's indoors, everyone's wearing masks. And you see a significant clear correlation about that with seasonal flu. But now what is missing is what is going to happen here. With flu B, it has those two different lineages. And again, why do we talk about flu A and flu B? So on one hand, from a clinical standpoint, most of it is they're quite similar from a presentation standpoint. They do present with the similar symptoms. There is some sort of data that says that flu B might be more causing more severe diseases in younger children. But overall, the management is quite similar, and the prognosis is also quite similar. But it is very important for informing vaccine design. So, when the vaccine has to be made, it has to incorporate the specific circulating strains. That's why it is very important to know which is flu A and flu B, because if you look at the vaccine that we get what is called as a trivalent vaccine and a quadrivalent vaccine. And these vaccines are based on this information that is coming out of surveillance. As far as symptom is concerned, when I started putting this slide together, when you look at it, it's quite similar. In a lot of ways, the similarities between the symptoms are quite similar. They all come with fever, chills, cough, body ache, with classic viral symptoms. And quite a lot of people will go to severe disease. They will have pneumonia. People with predisposing health conditions greater than 65 will have severe sort of condition. Will have a little bit worse prognosis. But there are slightly some differences which can be, if you start looking and say, okay, I can probably tell whether this is COVID or whether this is the flu. In the flu, you see a little bit more of the secondary bacterial complications that are super added onto the infection. And there are, interesting situation where you see a higher risk of complication in younger children. But what we see in COVID is a little bit different, right? It's actually, it presented with worse outcomes in grown-ups. The children actually did much better. But you had some of these interesting findings that we saw where you would see a loss of taste, complete loss of taste, people would not want to eat, loss of smell. And you had this, sort of what we call the cytokine storm, where you had people come in with acute respiratory distress because they would have this buildup of IL-6, and that would cause a lot of what we call the edema, pulmonary edema, where they would have certain breathing issues and they would need to go on a ventilator. And then you would also have, because of all the sort of the inflammation, you would have the blood clots and the sort of the situation we would go into sort of clotting. So these are some of the slight differences, but for majority of the people, the symptoms are quite overlapping. Very difficult to tell just based on whether you have, on the symptoms, whether you have COVID or flu. So as we go into, November, December, when we start seeing patients who are going to present with fever, chills, body ache, what is it going to be? So testing is going to be important to differentiate, and the reason it is important because the management is different, right? If you look at the management, right, in mild cases, most of them go on that mainly symptomatic treatments, right? Take rest, you don't have to do much, keep yourself hydrated, maybe a painkiller, antipyretic. But if you are with COVID, in moderate to severe cases, there is indications for getting people on monoclonal antibody therapy. You can actually give the patients remdesivir. It has been approved for use with patients with COVID. Also, because these patients have a lot of cytokine storm and their hyperimmune response, people are actually indicated for treatment with steroids. So you have remdesivir and steroids indicated in patients with COVID so that to bring their inflammation down. And then you have some immunomodulators like baricitinib or tocilizumab, where you can take an IL-6 inhibitor that is actually given to bring those levels down. The treatment is independent of viral variant at this point. Like I said, I think the viral variants is more for informing public health countermeasures, from transmissibility, or whether from vaccine it's important. But at this point, treatment seems to be it's not dependent on the variant at this point. For flu, the treatment is different. So you can see that, antivirals, if they are given within the first 48 hours with Tamiflu, is effective. You can also, and you also give antibiotics. You don't give steroids because actually steroids will suppress the immune response and make you more susceptible to bacterial infections. So in flu, actually, steroids are contraindicated as opposed to in COVID, where you want to actually give steroids to suppress the immune system. So the management actually fundamentally differs whether the patient is COVID positive or whether the patient is flu positive. So the only way to identify that is going to be through testing, because the clinical presentation is very similar, except for a few different symptoms. So when you look at the testing recommendations that is coming out of the CDC, so when you are, especially as we're going into a season where you can have both strains circulating, co-circulating at the same time, what the recommendation is to look at, especially for patients who are in the hospital or in nursing home residents, you need to order a test, that test for flu A, for flu and COVID at the same time. And for the ones that are not requiring hospitalization, that means you're sort of people who are just, asymptomatic or screening. First test by COVID, because of the COVID is the sort of the more public health emergency at this point. So first test for COVID. And then if not, if you move forward, then if it is required, then you can test for influenza. And if you can use a multiplex assay, that is better because it's more efficient to do it at once. And remember one thing and this is something we don't have data yet, but one thing that is going to happen is we should probably be expecting to see both infections occur at the same time. We say one versus the other, but I think it is something to say when you have a underlying sort of transmission level of COVID, there is going to be a possibility, I don't know what the probability will be, but there's a possibility that a patient can be co-infected with COVID and flu at the same time, and we don't know how those patients will progress and again, each patient will be different because of their underlying conditions. If you look at where these how they differ in their variants, we have this different what we call antigenic shift and antigenic drift for flu, and we have the different variants that we have. So again, very similar in some ways, but also a little bit different in some respects. I said a lot about why these variants are important, because a lot of that depends on the strain information is key on the development of the vaccines. So you can see, and vaccines do work. You have the flu vaccines that we take every year. It's recommended for high-risk groups. It's again updated annually based on what strains are circulating. And again, vaccine efficacy, interestingly, for the flu is around 40 to 60%. It has a trivalent and the quadrivalent vaccines. Right now, COVID vaccines, we are at a point where, we have three, at least in the US, we have 3 different vaccines, mRNA vaccines. It's recommended for everyone 12 years or older. We should see at some point it being approved for children between 5 and 12. And then also booster doses have been approved for high risk, greater than 65, and severely immunocompromised patients. Whether we will need boosters, that is something that is going to, that sort of should happen at some point. We will see what the decision is going to be made. So what was the impact? You can see, again, like I said, you can see all these different years. We see this very typical sort of seasonality pattern, and then we had nothing happening here during COVID. We will see how this graph progresses, but if things have opened up and we see children going back to school, and schools are sort of a breeding ground with children around COVID, around flu especially. So we should expect to see if we look forward, that flu to come back in some ways. We see, on TV, we see the games going on. People are doing, going to the games, playing, watching college football, NFL games. So and people going back to work. So if all of this is going to, if we are going in that road and the economy is opening up at some point, we should expect to see a rebound of flu. But again, we will see. At this point, the vaccinations, if you look at it, the world vaccination for COVID is around 42%. The US and some of the rest of the world, quite a good numbers are in their 80s or even higher. But overall, vaccinations have gone up. But what that means that public health countermeasures are coming down, because now people are feeling like we can get back to some sort of a normalcy. When that happens, why would you not expect to see some of these things that were impacted and things went down would want to go back up again? So you can see this, what we call the stringency index. You can see them, a lot of these stringency indexes were shutdowns, stay home, go back, don't come to work. But you can see a lot of them shifting from sort of the dark reds to the light reds, and maybe even some of the yellows. So which means we are reducing those sort of public health countermeasure, which means that we should expect to see a rebound increase in flu cases. So what are the concerns if you look at higher activity of flu is anticipated? We are easing our social distancing measures, and again, one of the things that is very important is there is limited data for the strains from the previous season, because there was no flu last year. So again, we'll have to see what is the likelihood of this impacted the season. So this is, again, both these agencies basically say that we strongly support the testing for multiplex COVID and flu at the same time. So what do we have at Thermo Fisher? We have the COVID, the SARS-CoV-2 flu A and flu B combo kit. This is a kit that is basically using is allowed for use with the nasopharyngeal swab in the antennae nasal swab, uses an automated sample prep with Kingfisher, and uses the same sort of the instruments that have been used for testing, which are the Quant Studio 5s or the ABS 7500 Fast DX. Takes about 3 hours to do it. We have the EUA for it. So this is how the kit is. Again, same workflow. You get the samples, you prep it, PCR, report. The limit of detection for these ones, for COVID, these are the sort of the GCE per ml, the TCI 50. I'm talking about both in TCID 50 and GCE, so you can see what those levels are. And again, these are at those levels that are required for that cause disease, as well as the levels, and also the different strains, as you can see, the H1N1, H3N2 covers all of those ones, including some other flu A types, as well as the major lineages in B. And this is sort of the inclusivity data that tells you all the strains that it can detect. So it certainly has the H1N1 in here, the H3N2, and a little bit else. You can see also the influenza B strains are covered by this assay. So it takes care of all the different strains. And this is the LOD for all of those. When we did the testing for the co-infections, you can see that it is highly accurate in the presence of, even with co-infections. So you can see when in this case we have a high flu A case and a low COVID, you can see that it can accurately detect either of the two agents here. Flu B is negative, and you have the control here, MS2. Similarly, in a situation here with flu B, high flu B, low COVID, flu A not detected. So these were all contrived samples. Again, we could not find cases which were co-infected. So these were, you have to contrive and do it from a sort of a co-infected situation. We did a clinical performance where we compared it against another test. Shows great positive percentage agreement and negative percentage agreement. It was on the kit that was compared against the Quidel Lyra assay. And for the SARS-CoV-2, we compared against because the Quidel Lyra assay is basically for the influenza A and B. For the COVID part of it, we compared against our own TACPath COVID-19 kit, and you can see that, again, great percentage agreement for the multiplex assay. So when you look at, this is the wrap-up slide, this is the final slide. So first part of my slide was around the surveillance part of it, and the next part is around flu. So it will continue to evolve with new variants. We don't know what the next variants will be. We are at mu, alpha, beta, gamma, delta, mu. It is going to be important as we go forward for surveillance testing. It's going to be critical. And especially, I say this word, especially in the ones that are capable of causing disease in the vaccinated. It's not about infection, it's about disease. And again, when we look at flu, I think at least, what we're seeing is with this relaxation of these public health countermeasures, I think, the multiplex testing is going to be important. It's good to be prepared as we go into the flu season with these tests. So, please, think about how you are planning to implement testing strategies in your lab and how you want to prepare for the next few, at least for the next year in 2021, and then 2022 flu season, we'll see. So thank you all for your attention.